Hi, everyone, and welcome to our lecture over the ANS, or better known as the autonomic nervous system. So, we're going to jump right into it. This is directly from the textbook, okay? So, the ANS is part of the peripheral nervous system. Its main function is to regulate life processes such as heart rate, blood pressure, body temperature, respiratory airflow, pupillary diameter, digestion, energy, metabolism, defecation, urination, and sexual functions. So, let's talk about it. So, the ANS, the autonomic nervous system, lies in the motor efferent division. So, remember, efferent exits. So, these are signals that are sent outward of the PNS, of the peripheral nervous system. In the ANS, it has two divisions of its own. So we have the sympathetic division and the parasympathetic. So remember, we talked just briefly about sympathetic, fight or flight, parasympathetic, rest or digest. Here we're going to get into it a little bit more. So what I want you to remember with the sympathetic, the fight or flight, are the 4 E's. So exercise, emergency, embarrassment, excitement. Okay? We're going to go through both of these lists, and then you can kind of look back at the 4 E's with sympathetic and see how those correlate. And then parasympathetic, rest and digest. We've got 3 D's. We got digestion, defecation, and diuresis. Okay? So again, we'll go through this list, and you can see how those correlate. So know that. Sympathetic, fight or flight, 4 E's. Exercise, emergency, embarrassment, excitement. So this is high stress, right? And then we have parasympathetic, rest and digest, 3 Ds, digestion, defecation, diuresis. This is relaxation, essentially. So stress, relax. So know these two, 4 E's, 3 Ds, fight or flight, sympathetic, rest and digest, parasympathetic. Quick definitions for dual innervation, we'll talk about in a second. Antagonists oppose each other. Synergists work together in synergy, unified, okay? Just real fast, because I'll talk about these momentarily. All right, so let's look at the chart. Let's look at parasympathetic nerves first, rest and digest. So starting at pupil constriction. So parasympathetics constrict your pupils. You don't need to see. You're sleeping, you're resting, you're relaxing. Your pupils are constricted. So they're smaller. Your saliva is stimulated. Parasympathetic nerves stimulate your saliva production. So that's part of the digestive process, right? That's technically step 1 of the digestive process. We'll talk about digestion next semester in anatomy and physiology too. Parasympathetic nerves are going to slow your heartbeat. So your heart rate slows down, slow, controlled. You're relaxing. Your airways, though, they're not going to be as relaxed. So they're going to be more constricted. While in this state, you don't need a ton of air. Your breathing is relaxed, it's slow, it's controlled, and your airways are going to be more constricted. They're not going to have to be relaxed and open and bringing in as much air as you can as in the sympathetic nerve. So we're not going to talk about that yet. Again, parasympathetic, relaxation. Your airways are going to be more constricted because you're not going to need as much air going in your sleeping, resting mode. Stimulate activity of stomach. So your stomach starts digesting. Along with that, you're getting bile from the gallbladder. Your liver juices are stimulated. Also, there's not as much glucose being released by your liver in parasympathetic. And your intestines are also getting to work a little bit harder. They're moving digestion along. The bladder contracts here. Gotta urinate. And then parasympathetic nerves promote erection of genitalia in both males and females. So again, those are all parasympathetic nerves. So now let's go down the list of sympathetic nerves. Down this list, fight or flight. So With fight or flight, with our sympathetic nerves, your pupils are going to be dilated. You're bringing in lots of light so that you can see what's happening, so you can see what's going on. Your salivation is going to get inhibited. So think of dry mouth. Think about when you're nervous. Let's say you're in a job interview, your mouth gets really dry, you need a drink of water. That's your sympathetic nerves, your fight or flight, your high stress. And that's going to inhibit your salivation. You're not going to produce as much saliva in this mode. Your heart rate is going to increase. Your heartbeat increases. Your airways, they relax to breathe more freely. So lots of air going in. Your stomach activity is inhibited. So think about if you have just eaten and you become under stress, or a different sort of stress, a physical stress, like if you become really, really active, but your sympathetic nerves are kicking in, your fight or flight is, and you just ate a big meal. So your stomach activity right now is inhibited, okay? So that means your food is not going to digest like it's supposed to. It's going to sit on the stomach. It's going to sit there, and it's going to sit there, and it's going to not be digested. What is another word for not digested? Indigestion. So you're going to have a lot of indigestion symptoms. You're going to have a lot of bloating, some gas. You're not going to be really feeling the greatest, which is just going to increase your sympathetics even more. We'll talk about that in a second. I won't get into that yet. But anyways, your stomach activity is inhibited. So you've got indigestion, and that's not going to be great for you, right? If you've just eaten. Let's see. Sympathetic nerves stimulate release of glucose, inhibit gallbladder. Okay, so stimulate release of glucose. You need sugar to the muscles. You need sugar to the brain. Sugar to the muscles prepares you to run any sort of fight or flight muscle activity that needs to happen, right? That your release of glucose allows that to happen. Your brain needs glucose, so that release of glucose is going to make you a lot more alert. It's going to increase your reactivity, things like that. So that's what happens with sympathetic nerves stimulating the release of glucose. Inhibits the gallbladder, so we're not in digestive mode right now, and same with intestines. We're not working to digest right now. Let's see, sympathetic nerves also secrete epinephrine and norepinephrine. Epinephrine is adrenaline. So when your sympathetics kick in, when you're in hypersympathetic mode, so a lot of sympathetics, you get a big kick of adrenaline here. Fight or flight makes sense, right? Big kick of adrenaline. And then your bladder is relaxed here, and sympathetic nerves promote ejaculation and vaginal contraction. So notice that the last two are both part of sex. That brings us to that term dual innervation that I just mentioned. Specifically of those organs. When it comes to promote erection of genitals, promote ejaculation and vaginal contraction, we are in a synergistic. We're here right now with dual innervation. So both your sympathetic and parasympathetic nerves go to the genitals. So dual innervation, both sets of nerves go to the genitals. When the two work together for a unified effect, we call that synergy, and they are synergists. Conversely, antagonists oppose each other. So that's most of these other ones. Slow heartbeat, increased heartbeat. Stimulates saliva, inhibits saliva. Constricts pupils, dilates pupils. Those are all antagonists. Our synergists, our unified effect, is down here with these. Promote erection of genitals, promote ejaculation and vaginal contractions. So let's talk about it. Parasympathetic is going to be vasodilation and erection. Sympathetic is going to be ejaculation, and vaginal contraction. Without either, or without one or the other, you're not going to get very far, right? You need both for success. You need both parasympathetic and sympathetic nerves to be successful here. So, an example, real life example. Let's say somebody is trying to get pregnant and they are worrying about it. So they'd be in a state that we just called hypersympathetic. So their sympathetic nerves are up, right? We're high. We're in fight or flight. We're stressed out. We're hypersympathetic. When we're in this state, sometimes these folks that are trying to get pregnant and they're worrying about it and they're in hypersympathetics are out of control. Sometimes they don't have that sex drive or libido, which we'll talk about more in AMP2, because they're in that fight or flight mode and the stress isn't making it better. Once they're actually able to relax, boom, pregnancy. If you've ever heard, that couple tried to get pregnant, but they kept worrying about it and stressing about it and worrying about it. And then once they stopped worrying about it, boom, they got pregnant immediately. That's actually real. Okay. So basically that tells you if you can't relax and you stay in sympathetic fight or flight, things like getting pregnant is going to be very, very, very difficult. Some other examples, stomach activity. If you stay stressed and you're not really digesting anything well, right, you're going to stay in this constant state of indigestion. That's going to cause food to sit. It's going to cause that food to sit and ferment. And that's going to cause bloating and gas, which is going to cause you more stress. So the hypersympathetic cycle is rough. If you're in this stressed out cycle, you have got to figure something out to get to the parasympathetic relaxation state, right? There has to be some sort of balance. You can't stay in this constant fight or flight, this constant arousal state without also resting and digesting. Stress is just going to make everything so much worse, right? And so figure out something, figure out how to get to that parasympathetic state, to that relaxation state. Try and find a daily or nightly ritual. For example, like right before bed, figure out something that you can do that's relaxing and non-stressful so that you're not going into sleep with very, fitful. If you're in this sympathetic state, you can still go to sleep, but it's going to be pretty fitful. It's not going to be relaxing, right? You want to be in your parasympathetic state for rest and digest to happen like it's supposed to. So constant stress puts a lot of strain on the body and you have to reach some kind of relaxed state somehow. Nightly rituals, come up with something like calm music, light a candle, read a book, watch a movie, take a bath or even a hot shower, maybe do yoga, maybe if cooking relaxes you, you can bake something, drink some tea, cozy up, listen to some nature sounds, put on low lighting, anything that can get you into a relaxed state. No hardcore working out. That's just going to put you right back into sympathetic, right? Your increased heartbeat, all of that. Okay, we don't want to be there. We want to be parasympathetic. So something more low-key. All right, well, let's move on. I think we've talked about that enough. All right, let's talk about some drugs. Effects of drugs on autonomic. So let's talk about some drugs that affect our ANS. Atropine, it's an anticholinergic, and it blocks our acetylcholine receptors. So atropine is anti-ACH, okay? It's given before surgery to dry up saliva and respiratory secretions. It's also used in eye exams to dilate the pupils. So those drops that your optometrist uses to dilate your eyes and then tells you can't drive afterwards without sunglasses, that's actually atropine. It blocks those ACH receptors and helps dilate your pupils so that your your optometrist can look in there. Antidepressants. So they prolong norepinephrine activity. Anytime you see capital N, capital E, it's talking about norepinephrine. Anyway, so antidepressants prolong norepinephrine activity on the postsynaptic membrane. So who remembers this from a few chapters ago? Remember, synapses have receptors to receive neurotransmitters. You remember that picture? Antidepressants keep those receptors working longer so that norepinephrine can attach and boost your overall mood. Some people have receptors that don't stay open very long, which causes that depression state, and antidepressants help keep those receptors open longer so that more norepinephrine can attach, and that'll boost your mood and get you out of that depression state. Nicotine. So this, we all know nicotine is in cigarettes, but it's actually also in products that are advertised to help you stop smoking. So why we talk about this is those products actually stimulate your sympathetics. Okay, so they increase your blood pressure. If you're having issues with high blood pressure already and you want to stop smoking to help that, then taking these products to help you stop smoking can actually keep you in that hypersympathetic state where your blood pressure is going to stay high or get even higher. So you got to be really careful if your blood pressure isn't under any sort of different control, whether it's, medicine or otherwise. Watch those smoking cessation products, or the products that are advertised to help you stop smoking. Okay? Because they still stimulate your sympathetic nerves and keep your blood pressure up, or increase it even more. Albuterol. So most of us have heard of albuterol. This gets prescribed for asthma and bronchitis. It dilates or opens up bronchioles. So bronchioles are passageways in your lungs. We'll talk about this more in AMP2. And bronchioles constrict with asthma or bronchitis and doesn't really allow airflow into the lungs. So we have to keep these open and dilated, and that's what albuterol does for us. It dilates our bronchioles. Propranolol. So this is an antihypertensive drug. It's for high blood pressure. So basically this one just decreases your blood pressure and your heart rate. So all of these are just some examples of the many, many drugs that affect our ANS, our autonomics. All right, so now we're going to move on to some conditions of the peripheral nervous system that are also autonomic. Okay, so one common one is called diabetic neuropathy. This is, like I said, common, so most of us have heard of this one. If you haven't, this causes nerve damage because of hyperglycemia, so high blood sugar. The nerves shrivel when blood vessels disappear, so that decreases our blood flow. Damaged nerves send weird signals, right? Pain when there's nothing hurting you, tickling sensation when there's nothing tickling you. Basically strange sensations from no external factors. That's where the neuropathy comes in. Things like feeling water running down your leg when there's no water running down your leg. Any weird signals that aren't caused actually by anything. Signs and symptoms. So any place a soccer glove would touch you would be numb. Paresthesia is that strange sensation that I was just talking about, the weird signals. Proprioceptive loss, so you can't tell where you are in relation to the position of your joints. You can't tell where your feet are. Hand-foot infections and ulcers. So these folks have loss of feeling in their feet and hands. They've lost that blood flow and that tissue begins to die, right? So messed up vessels, messed up nerves. Diabetics actually have to look to make sure that there aren't any sores on their feet because they're not going to be able to feel them. This is very, very important because if they do see a sore, they need to get that taken care of. Worst case scenario is tissue death. Okay, so when that happens, amputations have to occur. Okay, so folks with diabetic neuropathy really have to pay attention to their extremities. They're not going to feel it, so they got to look for it. What causes this? All right, so fats and proteins that have been overexposed to glucose, think in the walls of blood vessels. Oxygen can't get through the walls of the capillaries as easily. And then hypoxia, that's what causes that low oxygen in the nerve cells. Lack of oxygen slows down the nerve conduction velocity, and then change in that velocity causes the aberrant symptoms. So basically, too much glucose thickens the walls of the blood vessels, oxygen can't get through, hypoxia in the neurons causes nerve conduction to slow down, and that's what gives you all of those strange and weird symptoms. Bell's palsy. So notice, okay, remember anatomical position. So your left and this person's left is going to be a little different. Remember, it flips when we're looking at somebody, anatomical position. So notice the left versus right side of his face. The right side of his face has no control. So Bell's palsy is the inability to control the facial muscles on the affected side. Signs and symptoms include inability to raise the eyebrows, burying your lashes. So remember, that's to squeeze the eyes shut. Inability to smile, to flare a nostril, to frown. But remember, it's only on the affected side of the face. It's not going to be on both. Some causes can be viral. So viruses can attack anything. If they attack CN7, so cranial nerve number 7, that's the facial nerve. If CN7 gets attacked, it can cause Bell's palsy. Also, brain tumor can cause Bell's palsy. A stroke can cause this Lyme disease, or something called myasthenia gravis. That's an autoimmune disorder that we're not going to spend time talking about. Something to remember. Motor nerves to the upper face go to both sides of the brain, okay? So if your brain has had a stroke on the right side, then the left side of the brain would overcompensate, and then you wouldn't see any symptoms, okay, on either side of the face. Does that make sense? So motor neurons to the upper face go to both sides of the brain. So whether or not the left or the right side had a stroke, the other side would overcompensate and you wouldn't see any symptoms, okay? That's the upper face. The lower face is only served by the opposite side nerves. So that's called contralateral. Contralateral nerves. The lower face is only served by opposite side nerves. So a stroke is usually on one side and would affect the opposite side, lower face, and leave the upper face alone. So in this example, if this person's right eyebrow was going up just fine, then that would indicate that a stroke happened on the left side of the brain, if the eyebrow was raised the same as the left side eyebrow. Now, with this person, it's not, so this person probably did not have a stroke. That's a little bit of diagnostics there. Sciatica, so most of us have heard of this one as well. We've talked about the sciatic nerve. Here's a little reminder of where that nerve goes. So, sciatic nerve's right here. This is a piriformis muscle. And I think that's all you have to know right now. So, sciatica, it's a shooting pain down the back of the thigh and sometimes the leg too. Signs and symptoms include paresthesia, so those weird feelings, numbness, pain in the back of the thigh or leg. It can also cause shooting pain to the sides of the thigh and leg. Causes could be from disc herniation, spondylolisthesis, so that is when a vertebrae has slipped and pinched a spinal nerve. Usually this happens when a vertebrae cracks, which is not great, so you've got a lot of pain there. Stenosis, so your spinal canal is very narrow. That can cause this nerve to be pinched. Piriformis syndrome, so that piriformis muscle could be too tight and be putting pressure on or pinching that sciatic nerve. Pelvic tumor is another cause. And then pregnancy, of course, can also put pressure on or pinch the nerve. Because remember, the pelvis has that joint with the sacrum, and that kind of widens as pregnancy happens. And so think about how that baby sits and how that pelvis would shift and how that could put pressure on the sciatic nerve. All right, thoracic outlet syndrome, or TOS. So this area in purple here, this area, that is the thoracic outlet. It's where the thoracic cavity begins to open up. So there's a lot going on here. You have an anterior scalene muscle here. You have the brachial plexus right here, and denoted by these yellow nerves. You have the subclavian artery here. You have a clavicle, so it's kind of see-through. Kind of made the clavicle see-through so we could see behind it here. We have a subclavian vein. We have a first rib. There's a lot of activity in this little section. So it's very tight. It's a very busy area. If anything here gets inflamed, then you're going to have some symptoms. If any of the scalenes get tight, any of these scalene muscles, they can pinch the nerves and the brachial plexus, and then you can feel shooting pain going down your arm. If it pinches on the blood vessel, on the subclavian artery, you're going to obstruct blood flow. What can cause this? There are so many different causes. It could be trauma. It could be repetitive arm movements. It could be tumor. It could be pregnancy. It could be anatomical variation. So some people, for example, there can be several anatomical variations. I'm just going to give you one example, okay? Some people have an extra set of ribs. So technically, this is C7, okay? So this is cervical rib. So this is a really, really long transverse process, okay? This transverse process can actually be so long that it hooks all the way around and attaches to the sternum. So that's what that cervical rib would be. It's an extended transverse process on the C7 vertebrae. So what happens is surgeons can actually go in and cut that down, okay? So it can be a normal length again. Some people have taking that out of account. Some people that have a lot of pressure, a lot of stuff going on here, can actually get their first rib removed. That's a pretty common surgery that happens to allow for more space in this very, very busy area. Otherwise, there are going to be a lot of signs or symptoms there. Some other things that can happen: rotator cuff tear, cervical disc disorders, fibromyalgia, and MS. Okay. Or not that can happen, but that can cause thoracic outlet syndrome to happen. Okay, so rotator cuff tear can cause TOS, cervical disc disorders, fibromyalgia, MS. Okay. All right, some ANS imbalances. Okay, so imbalances. We're just going to touch on these. So first we have essential hypertension. So there's an imbalance here between the sympathetics and the parasympathetics. The sympathetics are going to be running a lot higher. We're going to be hypersympathetic here, okay, with essential hypertension. We have Raynaud's phenomenon. So this is increased sympathetic and decreased parasympathetic. So blood vessels in your hand, feet, lips are too restricted. They can ache, they can burn, they can tingle. They can turn blue. So they turn blue as oxygen is depleted in the tissues. The proximal fingers will turn white due to inadequate blood flow, and then the palms of the hands will actually be very, very red. And this happens more frequently in colder areas, and it becomes really, really bad in the wintertime as well. Autonomic reflexia. So this is overreaction to sympathetic input. So example would be low pulse but high blood pressure. So if there's a spinal cord injury, for example, you'll be sweating above the location of the injury and you'll have goosebumps below. So usually spinal cord injuries are neck C1 to upper back T6, and it's usually this autonomic dysreflexia is usually triggered by bowel and bladder problems below the spinal cord injury. So to make this make sense, this usually happens in paraplegics. So folks where the bottom half of their bodies are paralyzed from some sort of spinal cord injury, okay? So, for example, if they have a bladder infection, they wouldn't be able to feel that, okay? So what would happen is low pulse, high blood pressure, sweating above where the spinal cord injury happened, and goosebumps below that spinal cord injury. So a bladder infection you would need to signal, hey, I've got a bladder infection from a nerve going up to the brain, right? Well, because we have that spinal cord injury, it can't actually travel all the way up to the brain. That signal stops at the location of the spinal cord injury. So there are other things to trigger the brain, to let the brain know that there's a problem somewhere. So it can pick other cues up, like systemic signals from the blood that there's an infection. So even if that infection was taken care of, the brain might still think, oh, something's going on. So folks with spinal cord injuries, they are going to be assessed a little bit more thoroughly and a little bit more carefully for anything that can cause an infection below that point on the spinal cord where their original injury happened, because those folks can't feel it. Okay. So, like I said, systemic blood signals to let the brain know. Blood pressure here at its worst can get so high that can actually cause that person to die. So this autonomic dysreflexia it gets treated very, very seriously. And doctors pay special attention to make sure that they do find the infection and treat it appropriately. Okay. All right, we've got POTS. Okay, so POTS. We've heard of POTS. POTS stands for postural orthostatic tachycardia syndrome. So, another hypersympathetic. So, symptoms are going to be tachycardia, so high pulse, dizziness, tremors, purple hands and feet when standing, lack of temperature control, and sweating control. So, think about when you first stand up. If you don't have POTS, okay, and you first stand up, you can feel dizzy for a couple of seconds, but then you're fine, right? You bounce right back, you go do what you're going to do. With POTS patients, they don't recover quickly. It can take minutes. It can take hours. At the worst, it can take days. So their bodies try to compensate for a drop in blood pressure by increasing the pulse, which causes dizziness, right? And then your body tries to shove all that blood to your core so that your hands turn purple, okay? Because you don't have that temperature and sweating control. So hypersympathetic, fight or flight, you want to warm the core of your body. So that's going to be your trunk. So the blood is going to rush towards the center of your body. And that's why your hands and feet turn purple here with POTS. All right, and we got neurocardiogenic syncope. This is also called vasovagal syncope, hypersympathetic again, and this is another dizziness and heart rate condition. Neurodiagnostics. Okay, so the first one we're going to talk about is an EEG, an electroencephalogram. So here, doctors are going to record electrical activity of the brain using these little electrodes all over. Each electrode gives you a different pattern. So this is for patients that have had epilepsy, headaches, are unconscious, have had strokes, have degenerative brain disease. So this can also be implemented during surgery. So while someone is having surgery on their heart or neck arteries, EEG could be used to ensure blood flow to the brain is as it should be. All right, so another one, polysomnograms, aka sleep studies. So these have gotten pretty common. So this is a recording during sleep that uses EEG and other physiological monitoring during sleep. So if we were looking at the picture, we have a belt to monitor breathing, we have a microphone to record snoring, we have a nasal cannula to monitor airflow, and we have electrodes to monitor muscle movement. So overall, this is going to be really useful for snoring, insomnia, restless legs, and narcolepsy. And all of these different tests and electrodes, belts are implemented to find out what's obstructing your sleep. So by what the diagnostician or the doctor or the person administering this finds, they can give you the appropriate treatment. So if they find sleep apnea, so you've stopped breathing during your sleep, restarted, stopped, restarted all night long, if the diagnostician figures out that you have sleep apnea, they can prescribe you a CPAP machine for treatment to keep your airways open during sleep, right? So that you don't stop breathing while you're sleeping. So sleep studies are pretty fun, pretty interesting things to do. Evoked potentials. So this is pretty much what it sounds like. We try to evoke some sort of reaction. So here, these are recordings of electrical activity from the brain, spinal nerves, or sensory receptors before and after stimulation. So this checkerboard example on the right. Okay, so the patient would actually first look at a blank screen, and the electrodes are hooked up, and that activity is getting recorded. So then we add stimulation. So we would add the checkerboard screen. That's our stimulant. And then that brain activity would be recorded. So here we can test for vision issues. Testing for vision issues could see what parts of the brain are working and what parts of the brain are not working. And apparently with evoked potentials, you can pretty easily see which areas don't have electrical activity. We can do evoked potentials for sounds as well. Sounds can be used to evoke potentials for things like acoustic neuromas. So those are tumors that can affect our hearing. So this evoked potentials are useful in recording or in figuring out spinal cord injuries, hearing loss, blurred vision, blind spots. We just talked about acoustic neuromas, optic neuritis, and can be used during spine surgery itself. And then last but not least, nerve conduction velocity. So velocity, how fast something goes, right? So we're trying to figure out how quickly nerves are conducting. So nerve conduction velocity. This is really good with paresthesia, so those weird sensations and numbness. And then again, here we evaluate electrical potentials from peripheral nerves. So we know how fast these nerves should go. And with this test, we're kind of assessing how long did it take to get from here to here. Okay. How long did that take? And if it's normal, sweet, we're good. If it's not normal, we would go up the arm some. How long did it take to get from this point to this point? Okay. And we keep doing that. We keep going up the arm until we get to a section that's sending normal signals. So this is really useful for numbing, for tingling, for muscle pain, cramping, abnormal movements, pain, loss of sensation, neurological disease of neck, back, or extremities. Basically, it's a little electrical shock test, if you will, and it's really useful, and it points out exactly where a problem is. And that's all. That's all for this lecture.